Previously, we talked about parenterally administered indirect thrombin inhibitor, that is heparin. At this point, we shall start discussing the orally administered anticoagulant that acts indirectly at factor 2 or factor 2A, that is warfarin and related coumarin derivatives. But before we proceed on the actual discussion on the pharmacology of warfarin, let's have the historical examples first. When we talk about historical examples, these are orally administered as well. However, they were withdrawn from the market because of certain problems encountered. First is dicumarol. Dicumarol is being used as an anticoagulant before. However, due to increased risk of gastrointestinal bleeding and also ulceration, it is now being applied as a rodenticide, meaning rat killer. Another, we have indane-dione derivatives like phenyldione, but usage of that agent was already withdrawn or neglected nowadays because of the problems like thrombocytopenia and also fatal hypersensitivity reactions. That is why we will focus on warfarin. Okay? Warfarin being an orally administered indirect thrombin inhibitor. Warfarin, trivia lang, warfarin comes from coumarin derivative. That's why it has a suffix of arine, and WARF stands for Wisconsin Alumni Research Foundation. The Wisconsin Alumni Research Foundation was the organization that discovered warfarin being an anticoagulant. And currently, this is the orally administered drug used as an anticoagulant being applied in clinics. But as I've introduced last meeting, we have newer agents like apixaban and rivaroxaban, which are both administered orally as well. So this agent, going back to warfarin, this agent is an S isomer, which is considered as the active isomer possessing the pharmacological action resulting in bleeding. So right now, let's talk about the mechanism of action of warfarin. So meron tayo mga statements here that tell something about the mechanism of action. But I will focus more on this slide para mas mahimay pa natin siya o mas ma-elaborate pa natin siya. So when we talk about the mechanism of action of warfarin, basically, it does inhibit the hepatic synthesis of the so-called vitamin K dependent clotting factors. To be able for you to understand this further, let us break the statement. Let us focus on each significant term. Number one, we have the term hepatic. This is because warfarin acts in the liver. Okay? It acts in the liver where synthesis of clotting factors takes place. So doon nag-act ang warfarin sa liver. Another is, naka-state dito, ang action ng warfarin is focused on the synthesis. So pag pinag-usapan natin ang synthesis, it is expected that meron tayong precursor, okay, meron tayong raw material or precursor in which after a certain chemical reaction, mapoproduce ang certain product. Okay? Mapoproduce ang certain product. Mapoproduce a certain product. So that is synthesis. And then finally, we have the vitamin K dependent clotting factors. What do we mean by that? When we say vitamin K dependent clotting factors, these are the clotting factors that require vitamin K for their production or their synthesis. Meaning to say, there are certain clotting factors being produced in the liver na para magawa sila, kailangan ng vitamin K supply. Okay? And when we talk about these clotting factors, this could mean, number one, pwedeng mga pro-clotting factors. Okay? Again, number one, we have the pro-clotting factors. When we say pro-clotting factors, these are the ones that can promote 1A formation. Remember, as you learned previously, 1A is the one that strengthens the bridge, and it is the one that further stabilizes the clot. So examples of these pro-clotting factors that need vitamin K are factors 10, 9, 7, and also 2. Again, these are clotting factors 10, 9, Okay, 9, 7, and also 2. For everybody's convenience, you can think of the year 1972 to memorize the vitamin K dependent clotting factors. Okay, so pro-clotting factors that need vitamin K for their production in the liver are 10, 9, 7, and 2. Now, we also have clotting factors that are considered to be anti-clotting factors. Okay, anti-clotting factors. So meron din tayo mga anti-clotting factors na kailangan ng vitamin K for their production. So ito naman ay nagpo-promote ng bleeding. Okay, ng bleeding naman. Examples are protein C, okay, protein C, and also protein S. So protein C and S. So I repeat, these are protein C and S. So these are the anti-clotting factors that need vitamin K. So yan yung mga clotting factors, both the pro and anti, na may vitamin K na kailangan para sila ay magawa. Okay? So overall, nabanggit natin ang hepatic, ang synthesis, and the vitamin K dependent clotting factors. So going back to warfarin, again, going back to warfarin, as we mentioned, warfarin inhibits the vitamin K or the synthesis of the vitamin K dependent clotting factors. This is because, again, warfarin has the capacity, okay, it has the capacity to block an enzyme called vitamin K, vitamin K epoxide reductase complex. So because it inhibits the enzyme called vitamin K epoxide reductase complex. Okay, so it inhibits the vitamin K epoxide reductase complex, or simply called as VKERC. Okay, so ito yung binablock ng enzyme. That's why hepatic production of 1972 and protein C and S would be altered. Okay, yung production ay ma-alter o mapablock. So let us continue. Since you were able to understand that warfarin inhibits synthesis of both pro and anti-clotting factors, what would you conclude? Okay, what would you conclude? Ang mako-conclude natin dito is that, number one, by blocking the pro-clotting factor production, we tend to realize that warfarin causes bleeding. Okay? It causes bleeding because kapag na-block ang production ng 1972, ultimately, no fibrin will be formed, or walang ma-activate na fibrinogen. So pag walang na-activate na fibrinogen, no strengthening of the clot. That's why prone siya sa dissolution or breakage. Kaya ultimately, warfarin causes bleeding. However, it also targets production of the anti-clotting factors. That's why it also causes clotting. Okay? It also causes clotting. So it can cause bleeding and also it can cause clotting. So dito pa lang may konting confusion na kasi nagva-vary pala ang effect ng warfarin. Okay? So at this point, tandaan nyo muna na meron siyang bleeding effect at meron siyang clotting effect. Magiging realistic ito mamaya, magkakaroon siya ng sense later. Okay? So moving on, since we tackled that warfarin inhibits vitamin K dependent clotting factor production, magbigay tayo ng isang representative. Okay? Magbigay tayo ng isang representative. Ibig sabihin, in this portion, magbibigay tayo ng sample clotting factor na napoproduce because of vitamin K. So ang ibigay nating example dito is clotting factor 2. Okay, clotting factor 2. So that is, i-discuss natin ang prothrombin synthesis. Okay, discuss natin in this part ang prothrombin synthesis that happens in the liver. And then after that, we will incorporate the action of warfarin. Okay, we will incorporate the action of warfarin. So sa ngayon, wag nyo munang isipin na may drug. Dito muna tayo sa mismong prothrombin. Initially, prothrombin in the liver comes from a precursor. And that precursor is called, descarboxyprothrombin. Okay, so that is descarboxyprothrombin. Now, in the liver, ang descarboxyprothrombin, for it to become biologically inactive prothrombin, para siya maging zymogen na prothrombin, kailangan niya mag-undergo ng chemical reaction. And that chemical reaction is called, again, that chemical reaction is called gamma carboxylation. So that is called gamma carboxylation. So through gamma carboxylation, this carboxyprothrombin would become prothrombin, and when it happens, prothrombin again is already biologically inactive that only waits para siya ay ma-activate. So aantay na lang natin na ma-activate siya into 2A, for example, or thrombin hanggang maging 1A. Okay? So synthesis ang nangyayari. However, we must realize that for gamma carboxylation to happen, again, we must realize that for gamma carboxylation to happen, we need an ally. Okay? We need sacrifice. May magbibigay dapat. In this regard, ang magiging ally natin ay vitamin K. So in this case, ang form ng vitamin K na kailangan o yung active form ng vitamin K na kailangan in this process is hydroquinone. Again, that is hydroquinone. Regarding hydroquinone, again, this is the active form. This is the active form of vitamin K. So anong nangyayari? Para maganap ang gamma carboxylation, the hydroquinone or the active form of vitamin K must undergo oxidation reaction. So it must undergo oxidation reaction. That's why may incorporation ng oxygen dyan. And through oxidation of hydroquinone, may gamma carboxylation. Kaya nga ang tawag natin sa case ni prothrombin and other 1972 as well as protein CNS, sila ay mga vitamin K dependent clotting factors. Kasi kapag wala tayong hydroquinone na active vitamin K, walang gamma carboxylation, kaya wala kang zymogen. So pag wala kang zymogen, wala kang i-activate. Okay? Kaya siya vitamin K dependent clotting factor. Okay? Moving on. Suppose that oxidation of hydroquinone took place. So that means hydroquinone would be inactivated. And the inactive form of hydroquinone is what you call vitamin K epoxide. Okay, this is called vitamin K epoxide. And vitamin K epoxide, again, siya ay inactive form na. Okay, inactive form. Fortunately, vitamin K epoxide, which is inactive, could be reactivated back into hydroquinone. So pwede siya ma-reactivate pabalik sa hydroquinone. That is via reduction reaction. So to be able to facilitate conversion of epoxide to hydroquinone, kailangan natin ng enzyme. And that enzyme is VKERC. Ito yung sinasabi natin kanina na vitamin K epoxide reductase complex. So through this vitamin K epoxide reductase complex, mare-reduce ang epoxide into hydroquinone na naman, and then the cycle continues. Meron na namang kailangan for oxidation, may mako-convert na naman na descarboxyprothrombin, and then paikot-ikot siya. Okay? Kaya vitamin K dependent clotting factor. Okay? Now, going back to warfarin, as we discussed a while ago, warfarin has the ability to inhibit the enzyme VKERC. So, what's gonna happen? By inhibiting vitamin K epoxide reductase complex, we tend to conclude that conversion of epoxide to hydroquinone is blocked. Hence, hydroquinone level decreases. And time will come na pag sobrang konti na ng hydroquinone, wala na magagamit for oxidation. So pag walang oxidation, again, pag wala ng oxidation, gamma carboxylation will no longer happen. So kapag walang gamma carboxylation, we cannot form zymogen. Okay? We cannot form zymogen. And as such, walang magagamit for activation into 2A. And as you learned, pag walang na-activate na 2A, wala tayo eventually 1A. That's why ang warfarin, by blocking for instance 1972, okay, like prothrombin, there is bleeding effect. Okay, there is bleeding effect. Okay? So yan ang mechanism niya in causing bleeding. However, we mentioned again, we mentioned that aside from inhibiting production of 1972, which causes bleeding, it also targets production of protein CNS because protein CNS also require vitamin K para ma-produce sila. So since warfarin targets vitamin K activation, wala tayong protein CNS kaya nagkukos ng clotting ang warfarin. Okay? So therefore, because of this knowledge that you obtained, ang susunod na question is, kailan o paano mararamdaman ang effect ng warfarin na bleeding at kailan mangyayari ang effect ng warfarin na clotting? Time matters, timeline matters. Okay, timeline matters. So bago tayo mag-discuss ng indication, again, bago tayo mag-discuss ng clinical indication, isingit muna natin dito ang onset of effect ng warfarin. When we talk of onset of effect, between bleeding and clotting, ano ang unang mangyayari? Ano ang unang mangyayari or ano yung unang magiging effect? So initially, ang magdodominate na effect would be procoagulation. Again, ang initial effect ay procoagulation. Procoagulation is telling us na magkakaroon ng clotting sa umpisa, clotting. However, ang final effect o yung lasting effect ng warfarin would be anticoagulation eventually. Anticoagulation. Anticoagulation meaning magkakaroon na siya eventually ng bleeding effect. I repeat, initially it's clotting and then ultimately it would become bleeding. It would become bleeding. So, i-rationalize natin bakit sa umpisa ay bleeding, but sa umpisa clotting and then sa huli merong bleeding. Bakit clot muna, then bakit bleed? So i-explain natin siya by having this sample scenario. Remember, tandaan, ang tinatarget ng warfarin ay synthesis ng clotting factors, yung production. Ibig sabihin, yung paggawa ng clotting factors, both the pro and the anti ay mabablock in the liver. So anong implikasyon niyan? Anong pinaparating nito sa atin? Malaking factor dyan ang timeline, yung timeline kung kailan nag-start mag-take ng warfarin ng isang tao. So for example, meron tayong timeline na ipapakita. For example, on the left side, halimbawa dito, without warfarin, meaning hindi pa siya umiinom, and then after naman, with warfarin na, with warfarin use. So we have to realize that sa time na kung saan wala pa siyang iniinom na warfarin, dito nagpo-produce na ng clotting factor ang liver natin. So halimbawa, habang walang iniinom na warfarin ang patient, meron na agad preformed 1972, may preformed 1972 na, meaning nagawang 1972, and then meron na rin preformed protein C and S. Pag sinabing preformed, nagawa kahit wala pang iniinom or habang wala pang iniinom na warfarin ng isang tao. Okay? And then, tandaan natin, by the time na uminom na siya ng warfarin, doon pa lang mabablock ang synthesis, ng 1972 at ng protein C and S. So, ibig sabihin, yung portion na to lang ang sakop ng warfarin, pero yung part na ito, hindi niya sakop kasi na-preform na siya. Bago uminom ang patient ng warfarin, na-produce na siya. So ang mangyayari dito is, kailangan palipasin natin yung effect ng mga clotting factors na preformed. We have to let this maubos. Kailangan maubos natin siya. So ang pag-uusapan naman natin dito, sinong unang mauubos? Kasi pag nalaman natin kung sinong unang naubos, dun mo malalaman kung sino ang initial at sino ang final. Number one, regarding 1972, ang half-lives kasi, again, ang half-lives ng 1972, that is from 6 to 60 hours. Again, ang half-lives ng 1972 ay 6 to 60 hours. While ang protein C and S, that is from 6 to 24 hours. Again, ang preformed or yung half-lives ng 1972 ay 6 to 60 hours at ang protein C and S 6 to 24 hours. Now, if you will check the half-lives, mas mabilis maubos ang protein C and S. Therefore, by the time na ininom mo ang warfarin at kinalculate natin kung sino unang mauubos, ubos agad ang protein C and S, mas mabilis siyang mauubos. Question, pag naubos ang protein C and S, what's gonna happen? Siyempre, nauubos ang anti-clotting factors protein C and S mo, kaya pag naubos siya, ang magdodominate ay pro-coagulation. Kaya merong pro-coagulation effect. Okay? Merong pro-coagulation effect. So that is for protein C and S. Una kasi siyang nauubos. And then, finally, habang tumatagal ang inom ng warfarin, time will come that the preform, meaning before taking warfarin, na 1972, mauubos na. Kaya mauubos na. So pag naubos na yon, mauubos ang pro-clotting factors mo, kaya eventually ang effect ay anti-coagulation. Okay? Kaya eventually ang effect ay anti-coagulation. So that's it. So yan ang onset of effect with the use of warfarin. Okay? Medyo nakakalito siya, so practicein lang. Tandaan, synthesis ang target niya. Parehas tina-target ang 1972 at protein C and S. Since mas mabilis maubos ang preformed protein C and S, mauuna ang pro-coagulation. At ang huling nauubos yung preformed 1972, kaya eventually anti-coagulation. And then, habang iniinom mo ang warfarin, wala na magagawang 1972, tapos ubos na yung mga preform, talagang warfarin na ang magdodominate. Okay? Siya na yung magdodominate sa katawan ng tao. That is the onset of effect. Okay? Let us continue. Guys, the main reason why a patient uses warfarin is to produce bleeding, or that is to prevent clot formation. So therefore, we can actually infer that the initial effect of warfarin, which is pro-coagulation, is adverse. Adverse. That's why this has to be masked. This has to be masked. So ibig sabihin ng masking, dapat itago yung effect na yan. So ang effect or yung yung drug that could mask the pro-coagulation effect of warfarin, that is heparin. So hence, ang remedy natin dito is co-administer warfarin with heparin. Okay? We have to co-administer warfarin with heparin. Okay? So that is the remedy. Recall that heparin is parenterally administered, producing a brief onset of bleeding or anticoagulant effect. Okay? So overall, yan ang actions ng warfarin. Okay? Yan yung actions ng warfarin. Okay? Next, moving forward are the clinical indications. The following are the clinical uses of warfarin. Since warfarin is being administered orally, we usually think na kapag orally administered for chronic application na siya, long-term anticoagulation therapy. And it is correct. Warfarin is being used in the management of disorders requiring chronic anticoagulation. Like for instance, when a patient has deep vein thrombosis, also kapag merong ischemic heart disease, rheumatic heart disease, and lastly, pulmonary embolism. So those are the clinical applications of warfarin. Okay? Next, please remember that warfarin is a drug that has a narrow therapeutic window. When we say narrow therapeutic window, even minute or small modifications or small changes in the dose of the drug administered, that can result to drastic effect. So since may ganong characteristic ang warfarin, it has to be monitored. So the monitoring test being conducted to test if warfarin is still safe or not anymore to the patient is the PT-INR. For most patients, the goal is dapat 2 to 3 ang value ng PT-INR, but in some cases, lalo na sa mga patients with prosthetic heart valves, ang objective natin, ang normal PT-INR natin ay 2.5 to 3.5. Okay? Now, what if the goal was not attained? Paano pag hindi na-achieve yung goal? For example, pag ang nakuha ay less than the goal. Again, what if ang nakuha ay less than the goal? Halimbawa, instead of 2, naging 1.5, naging 1.3. What does it tell us? What does the result tell us? So kapag mas mababa, tandaan, ibig sabihin, kinulang ng warfarin. Okay, kinulang. Kaya ang patient is at risk, okay, at risk of thrombosis. The patient is at risk of thrombosis or clotting. Whereas, pag mas mataas naman, meaning toxic na ang warfarin. Okay? It's already toxic, kaya mataas ang risk ng hemorrhage. Okay? Mataas ang risk ng hemorrhage. So if you check the PT-INR of a patient using warfarin, tendency, pag nakita nyo na less or more, merong implikasyon yon. It's either subtherapeutic or toxic na ang warfarin. Okay? That is the monitoring. Okay? Next. Okay, next. Regarding the drug interactions of warfarin, involving warfarin, please remember that warfarin is an example of a drug that actively participates in several drug interactions. With that, meron siyang connection, meron siyang implication on the result PT-INR of a patient. Tandaan, when warfarin participates in a drug interaction, it could either increase or decrease the PT-INR. Okay? It could either increase or decrease PT-INR. When we say increase PT-INR, warfarin's effect is already exists or masyado ng malakas yung effect ng warfarin. Pag naman mababa, subtherapeutic siya. Number one, let's have increased PT-INR kapag drug interaction. Again, there is hemorrhage. So we have both kinetic and dynamic drug interactions. Take note, kapag kinetic interaction, you must know this, na kapag kinetic interaction, there must be modification or alteration of the ADME of warfarin. So it's either absorption of warfarin was altered, distribution, metabolism, and excretion. Number one, we have reduced plasma protein binding. Like for instance, when a patient takes warfarin concomitantly with pyrazolone derivatives. Pyrazolone derivatives like phenylbutazone. Again, example is phenylbutazone. So what do we mean by reduced plasma protein binding? This tells us that when warfarin is taken together with phenylbutazone, that could enhance displacement of warfarin from the protein binding sites. Kaya ang tendency, tumataas ang free warfarin, tumataas ang free drug warfarin available for action. You learned, of course, that increased levels of free drug would mean greater amount available for action. With that being said, pag maraming warfarin ang free, di marami ang responsible in causing bleeding, lalo na pag long-term drug interaction. So that's why that could cause increased PT-INR. Another, we have enzyme inhibitors. Enzyme inhibitors basically are the drugs that would inhibit metabolizing enzymes for warfarin. With that, napipigilan ng mga drugs like amiodarone and other related agents, napipigilan nila ang deactivation ng warfarin. Kaya warfarin's active form is being sustained. So sustained warfarin levels tells also na na-extend yung action niya, which is bleeding, increasing PT-INR. Okay? So yan ang mga kinetic drug interactions. Question, bakit siya kinetic ulit? Number one, yung unang drug interaction kasi na-alter ang distribution. Okay? Kasi maraming free. Yung enzyme alteration naman, like enzyme inhibition, metabolism yan. Okay? Na-alter ang metabolism. Moving forward, we have dynamic drug interactions. Sa dynamic naman, this must fall into either additive effect, synergism, potentiation, or antagonism. So if a drug interaction falls in either of these, dynamic siya. Number one, if warfarin was taken concomitantly with aspirin at high doses, that causes bleeding. Okay? That can cause bleeding. So there is additive effect, of course. Next, third generation cephalosporins. Usually, class, kapag gumagamit ang patient ng warfarin at ng antibiotics, kagaya ng third generation cephalosporins, may effect siya. Kaya meron siyang effect. Mind you that third generation cephalosporins are broad spectrum. Okay? These are broad-spectrum antibiotics. So, kung broad-spectrum antibiotics sila, they can kill both the good and the bad bacteria. So, ang effect niyan is when third-generation cephalosporins are taken, even the good ones are being killed, such as the intestinal flora. So, they are broad-spectrum. They are both broad-spectrum. That's why they can kill intestinal flora. Okay, they can kill intestinal flora. Now, killing of intestinal flora could affect production of vitamin K sa pasyente. So pag napatay ang intestinal flora, this could lead to decrease in vitamin K level sa pasyente. Okay, so it can decrease vitamin K levels in patients. Now, anong kinalaman ng decreased vitamin K supply kapag na-enhance ang effect ng warfarin? When we go back to the mechanism of action of warfarin, you can actually see here, makikita nyo rito class, na pag gumamit ka ng warfarin, nabablock ang enzyme, kaya ang supply ng vitamin K sa tao bumababa. Tandaan, ang warfarin ay mortal na kalaban ng vitamin K. Pag gumagamit ang patient ng warfarin, bumababa ang levels ng vitamin K. Tandaan nyo yan ha, bumababa ang levels. Particularly dihydroquinone form. Pinipigilan kasi ng warfarin ang activation, di ba? Kung naaalala nyo. So kung babalik tayo sa drug interaction, since ang paggamit ng cephalosporins ay nagpapababa ng vitamin K, that would cause less or more effort kay warfarin to cause bleeding. Less or more effort. So that is lesser effort kay warfarin kasi konti ang kanyang kalaban, konti ang kanyang ibablock ang reactivation. Kaya na-extend further ang effect ng warfarin that causes bleeding as well, okay? Increasing PT-INR. Next, kapag may prolonged use of heparin, that can also cause bleeding. Although we said that in certain cases, co-administration of heparin with warfarin is beneficial. Pero heads up, dapat short-term lang ang use ng heparin. Meaning to say, pag lumipas na ang pro-coagulation effect ng warfarin, pwede nang stop ang heparin use. Okay? So dapat merong time frame lang ang paggamit ng heparin with warfarin. Also, patients with chronic liver disease have impaired clotting factor production. So kapag may impaired clotting factor production, pag uminom pa siya ng warfarin further impairs clotting factor production, right? So ini-impair din ng warfarin. So additive effect yun. And also, hyperthyroidism. The mechanism is still unknown, but increased levels of thyroid hormones could enhance anticoagulation effect of warfarin. Next, what about drug interactions that can decrease the PT-INR? So when we say decrease PT-INR, that you must note here na may less effect of warfarin causing clotting or thrombosis. So like kanina, meron ding kinetic and meron ding dynamic. So sa kinetic, kabaliktaran lang, enzyme inducers naman dito. Enzyme inducers are the ones that can activate metabolizing enzymes against warfarin, such as barbiturates and rifampicin. So kapag may concomitant use ng enzyme inducer with warfarin, these enzyme inducers can lower the level of warfarin because of enhanced metabolism of warfarin. Okay? So kapag mababa ang warfarin level, decrease PT-INR. Next, we also have drugs that can prevent absorption of warfarin. So for example, we have the bile acid sequestrant. Okay? For example, we have the bile acid sequestrant cholestyramine, and also we have sucralfate, So examples of drugs that can prevent absorption of warfarin are cholestyramine and also sucralfate. We will discuss this sa susunod na lesson. But for now, take note, if taken together with cholestyramine o kaya sucralfate, less amount of warfarin will enter into the bloodstream kasi absorption ang ina-alter. Less amount of warfarin that entered the blood dictates na lesser activity for warfarin. Kaya bababa ang PT-INR. Finally, we have dynamic. Again, pag dynamic, dapat may kinalaman ito sa addition, synergism, potentiation, and antagonism. So una, we have vitamin K. I discussed this a while ago. There is antagonism between vitamin K and warfarin. That's why if nakita nyo na somewhere, ang antidote natin for warfarin poisoning is vitamin K. That's vitamin K. Kasi when you supply vitamin K to the patient, it would be harder for warfarin to counteract those active vitamin K. Kasi ang goal ng warfarin, i-counteract yun, di ba? Or i-block ang production, or not production, i-block ang reactivation ng vitamin K. And then we have hypothyroidism. Kabaliktaran lang to ng kanina. Next, after we discussed the drug interactions involving warfarin, let us proceed on the undesirable effects of warfarin. Toxic effects caused by using warfarin are the following. Number one, cutaneous necrosis. This could happen within the first week of treatment. This happens because of the procoagulation caused by warfarin. Remember, bakit nagkaka-procoagulation? Kasi ano ang unang nauubos? 1972 or protein C and S? Yes, that is protein C and S. So yung procoagulation ay nakaka-counteract nga natin ang procoagulation ay na-prevent ka natin because of co-administering warfarin with heparin. So ito, may remedy. Nasa previous notes natin yon, co-admin with heparin. But sabi nga natin, dapat specific ang time frame. Otherwise, there could be a significant drug interaction causing bleeding. Also, we have purple toe syndrome, bleeding or hemorrhage. And as we said, once this occurs, lalo na kapag potentially fatal na sa patient, ang antidote natin is vitamin K. I suppose may idea na tayo kung bakit vitamin K ang antidote. You can double check the illustration that we showed a while ago. Ito, okay? Yan yung sasagot doon sa antidote na vitamin K. Next, we have gastrointestinal upset. And take note, there could be complications in pregnant women. That's why use of warfarin is contraindicated to pregnant women. Complications mismo sa mga fetus. Kasi ang warfarin ay teratogenic. Warfarin is teratogenic. So within the first trimester, there could be, kapag ininom siya during the first trimester, there could be abnormal bone development, which is a teratogenic effect. And then, kapag third trimester na binigay ang warfarin, there could be hemorrhagic disorder of the newborn. And this is fatal. That's why when we compare warfarin to heparin, heparin is relatively safer to pregnant women, particularly the low molecular weight heparin. Okay? So overall, that marks the end of the pharmacology of warfarin. Going back, warfarin is orally administered for long-term anticoagulation therapy. And then, may MOA tayo na binablock niya ang VKERC in the liver, kaya ang hepatic synthesis ng clotting factors requiring vitamin K nata-target. Di ba pag vitamin K dependent clotting factors, may pro at may anti, di ba? Ang pro, kapag na-block ang production ng pro-clotting factors, nagkakaroon ng bleeding. And then kabaliktaran naman yung isa. And then, pag uminom ka ng warfarin, medyo delayed yung effect niya kasi ang nauubos na preformed clotting factors at first ay ang, yes, protein C and S. That's why you have to co-administer it with heparin. And then, pag sa huli, ang nauubos ay 1972, dun palang magkakaroon ng anti-clotting effect o nagkakaroon ng bleeding effect. And then, drug interactions that can increase or decrease PT-INR and then the adverse effects. So that's the end of warfarin. So overall as well, from the previous meeting until now, natapos na natin ang mga anticoagulants. Recalling anticoagulants, both direct and indirect thrombin inhibitors, they target the coagulation cascade. So sa next video na gagawin ko, that would include antiplatelets already and other related blood drugs or coagulation disorder drugs. Okay? So that's for anticoagulants. The second classification of antithrombotic agents are the antiplatelets. Previously, you learned that antiplatelets are medications that target the first event of hemostasis. That is, yung mga substances and the entities that the platelets possess, yun ang tatargetin ng mga antiplatelets. Bottom line, antiplatelet effect would be bleeding. Okay, bleeding. Ang challenge lang natin dito is, bakit nagli-lead sa bleeding? Yun ang i-discuss natin. We have four major examples of antiplatelet agents. Number one, we have the thromboxane A2 synthesis inhibitor in the name of aspirin. Second, we have adenosine diphosphate receptor antagonists, or the ADP inhibitors, in the name of ticlopidine and clopidogrel. We also have phosphodiesterase or adenosine uptake inhibitors. These are dipyridamole and cilostazole. And finally, we have glycoprotein 2B3A inhibitors like eptifibatide, abciximab, and tirofiban. We will discuss them individually in terms of their mechanism of action, bakit sila naging antiplatelet, bakit sila nagkakos ng bleeding, and after that, i-discuss natin ang distinct properties nila as well as clinical uses. First stop is aspirin. Aspirin is the prototype NSAID, that is the prototype non-steroidal anti-inflammatory agent. Now, being an NSAID, aspirin can cause analgesic action, antipyretic action, anti-inflammatory as well. But since ang focus natin ay pagiging antiplatelet niya, we must specify that aspirin, for it to produce an antiplatelet effect, the dose of the drug that must be given should be not more than 325 milligrams per day. Again, that is not more than 325 milligrams per day. Well, actually, there was a clinical study that tells na ang aspirin, the lower the dose, the greater the antiplatelet effect. Okay? The lower the dose, the greater the antiplatelet effect. So that is for aspirin. Hence, in the Philippines, ang commercially available aspirin na antiplatelet ay 80 milligrams. Now, the question is, bakit kaya specific ang dose ng aspirin as an antiplatelet? That is because aspirin is directed towards platelets kapag ganyan ang dose. Kaya right now, pag-usapan natin kung ano ang ginagawa ng aspirin in the platelets. Okay? In the platelets. Aspirin is an NSAID, and at this given dose, it can block COX-1 in the platelets. So what will happen kapag na-block ni aspirin ang COX sa platelets? Remember that COX is an essential enzyme in the production of prostanoids. And cyclooxygenase is important particularly para makapag-produce tayo ng intermediate prostaglandins PGG2 and PGH2. Okay, that is the PGG2 and PGH2. Now, pag binlock ni aspirin ang COX, that would result to inhibition of prostaglandin formation. Question, in the platelets, how essential are these prostaglandins? Mind you, these prostaglandins are important in the synthesis of thromboxane A2. Therefore, pag na-block ni aspirin ang COX-1, indirectly, nabablock din niya ang thromboxane A2. Bakit indirect? Kasi it doesn't actually block thromboxane A2 itself. No. But it targets the synthesis. Okay? But it targets the synthesis of thromboxane A2. Question again, what's the importance of thromboxane A2 in the platelets? Remember that thromboxane A2 is a potent platelet pro-aggregant. Okay? Di ba siya ay nagkukos ng pro-aggregation? When we say pro-aggregation, this means that thromboxane A2 invites other platelets to join to be activated, causing aggregation, right? Pero, pag gumamit ka ng aspirin, no synthesis of thromboxane A2. Hence, pag gumamit ka ng aspirin, that would result to low thromboxane A2 levels. Okay, bababa ang thromboxane A2 levels. And lowering of thromboxane A2 would mean lesser aggregation, causing bleeding. Okay, that's why ang aspirin ay isang anti-platelet drug kasi ang thromboxane A2 ay nag-act sa platelets. Okay? So as we said, aspirin is responsible for the antiplatelet effect at the given dose, not more than 325 milligrams per day. And its main application is first-line antiplatelet siya for the prophylaxis of myocardial infarction, primary prophylaxis, and secondary prevention as well in certain vascular thromboembolic events, like for instance in patients with history of valvular disease. So that is aspirin. So the major toxicity associated with aspirin use, syempre, extend, since NSAID siya, ay prototype NSAID, ang aspirin ay nagkukos ng gastrointestinal disturbances. Kaya yung adverse effect niya, pinaka-common is aspirin can cause gastrointestinal disturbances. So that is the reason why, although it is first line, napipilitan ang ibang patients or ibang doctors na i-shift ang patients into using other antiplatelets. Like for instance, my mom, nabigyan siya before ng aspirin, but because of GI disturbances, nag-shift siya into using other antiplatelets, mamaya madidiscuss natin yon. Okay, so that is aspirin. Before I forgot, take note, ang action ng aspirin in blocking COX-1 in the platelets, that is through irreversible acetylation. Okay, that is through irreversible acetylation of COX in the platelets. Okay, that is irreversible acetylation, done with the MOA of aspirin. Next, let us proceed to ADP inhibitors. Okay, proceed naman tayo sa mga adenosine diphosphate inhibitors or ADP antagonists. Chemically, we have the irreversible, we have the irreversible ADP inhibitors. Chemically, these are called as thienopyridines. I repeat, chemically, irreversible ADP antagonists are thienopyridines. Specific examples are clopidogrel and also ticlopidine. Palatandaan dito may clop, kaya may clop sa pangalan. Okay, ticlopidine, and also we have clopidogrel. So right now, let us discuss the mechanism of action. Okay, mechanism of action ng clopidogrel and also ticlopidine. So with these agents, take note, clopidogrel and ticlopidine, they have the ability to block, purigenic receptor. Okay, they can block the purigenic receptor, particularly the purigenic receptor P2Y, P2Y12 receptor. Again, clopidogrel and ticlopidine, these agents are the ones that block purigenic receptors, particularly the P2Y12 receptors. Now, ang question dito is, what is the relevance of blocking purigenic receptors, and how can we relate that to the term ADP inhibitors or ADP antagonists? So for you to understand that, let us refer, everybody please refer on the figure on the right side. Number one question, ano ba ang purigenic receptors? Ano ba yung purigenic receptors? Ang purigenic receptors, ito yung receptor na binabindan, pinupuntahan ng adenosine diphosphate. Doon siya merong affinity, in causing aggregation of platelets. Okay? So again, ang purigenic receptors, ito yung receptors na pinupuntahan ng adenosine diphosphate in causing aggregation. Remember, pag aggregation, it means clot. Okay? Clot. At the end of the day, ang alam natin, adenosine diphosphate can cause clotting kasi pro-aggregant siya. So right now, i-connect natin ang adenosine diphosphate to the receptor. No clopidogrel yet, wala muna tayong gamot, yung ADP muna. Ang adenosine diphosphate, it binds to purigenic receptors like P2Y12 and P2Y1. Okay, P2Y12 and P2Y1. Doon muna tayo sa less important na P2Y1. Ang P2Y1, siya ay isang GQ-linked receptor, okay, GQ-linked. That's why you can expect that there is increased calcium inside the platelets. That would result to platelet aggregation. Okay, it causes platelet aggregation. Next, paano naman yung action ng ADP sa P2Y12? Sa P2Y12 receptors naman, these receptors are GI-linked. Okay, GI-linked. So kung GI-linked siya, inhibitory receptor siya. So pag sinabi nating GI link, okay, pag sinabi nating GI link, P2Y12 tayo ha, doon kayo tumingin, ang effect ng GI link receptor, pag inactivate siya ng ADP, na i-inhibit niya ang enzyme na adenylyl cyclase. Okay, na i-inhibit niya. Kaya meron ditong broken arrow na papunta sa AC. Kasi ang broken arrow, it signifies inhibition. Okay, inhibition. Okay, again, it signifies inhibition. Now, pag na-block ang adenylyl cyclase's action, ang mangyayari is ang camp level bababa. Okay? Bababa ang camp levels. So I repeat, that can cause lowering of camp levels. So tandaan, kapag mababa ang camp levels, that can further enhance activation of glycoprotein 2B3A receptors. Again, that could further enhance activation of glycoprotein 2B3A receptors. Now, kapag na-enhance natin ang activation ng glycoprotein 2B and 3A receptors, remember, these receptors are important for interplatelet binding. Kaya further, nagkakaroon ng platelet aggregation. Okay, that's why there is platelet aggregation. Hence, ang ADP, both purigenic 12 and purigenic 1, ang effect niya ay aggregation. Okay? So yan ang action ng adenosine diphosphate. No drugs yet. Again, no drugs yet. So right now, proceed tayo sa gamot. Ang clopidogrel at ticlopidine, they block purigenic 12 particularly. Okay? They block purigenic 12. Inhibition of purigenic 12 receptors would tell us na AC remains activated. So kapag activated ang AC, again, pag activated ang adenylyl cyclase, palitan natin ang color, pag activated ang adenylyl cyclase, that can increase camp levels. And take note, camp is an example of an anti-aggregant. Anti-aggregant siya. It is an anti-aggregant because it blocks further activation of glycoprotein 2B3A. So less activation of 2B3A would inhibit binding of the bridge. So walang didikit na bridge. So ang tendency, walang interplatelet binding, antiplatelet effect. Okay? Antiplatelet effect. So yan ang mechanism of action ng thienopyridines. Okay? Yan ang mechanism of action. Now, since natapos tayo sa irreversible, which are thienopyridines, meron naman tayong reversible ADP inhibitor. Again, meron tayong reversible. Ang reversible naman, ang example ay si ticagrelor. Okay, ticagrelor. Siya yung example natin. Again, example ng reversible ADP antagonist. Okay, that is the example of reversible ADP antagonist. So let's focus on thienopyridines like clopidogrel and ticlopidine. Between the two, ang mas ginagamit nowadays ay clopidogrel. Okay, mas commonly used ang clopidogrel. In fact, ito yung sinasabi kong drug na naging alternative ng nanay ko instead of aspirin. Okay, instead of aspirin. So bakit kaya mas common ang clopidogrel kaysa kay ticlopidine? That is because with the use of ticlopidine, there is increased risk of blood effects, blood toxicities like neutropenia, and also thrombocytopenia. Okay, again, there is increased risk of neutropenia and thrombocytopenia. Ang neutropenia meaning mababang neutrophil count, or in other books, leukopenia ang sinasabi. Sa leukopenia naman, in totality kasi yun na leukocytes. Pero ang pinaka-distinct ang pagbaba ay neutrophil count. Okay, that is neutropenia. Now, anong implikasyon pag mababa ang neutrophil count ng pasyente? Mataas ang risk na ma-expose siya o magkasakit siya magka-infection. So increased risk of infection. Okay? Increased risk of infection. Now, ang thrombocytopenia naman could be associated to further bleeding, di ba? Further bleeding. That's why ang ticlopidine hindi na siya ginagamit nowadays. Ang common na ginagamit ay ciclopidogrel kasi less associated siya sa mga problems na sinabi natin. Okay? Less associated siya sa mga problems na nabanggit natin. Okay? In addition, ang clopidogrel is more potent. Okay? More potent than ticlopidine. Okay, this is more potent than ticlopidine because you only need 75 milligrams once a day administration of ticlopidine. Okay, you only need 75 milligram administration per day, okay, once a day. Unlike ng ticlopidine, you need 250 milligrams, okay, 250 milligrams twice daily. So, mas okay gamitin ang less frequent na i-take kasi higher patient compliance, di ba? Higher patient compliance. Okay? So, that is for clopidogrel and ticlopidine. Next, we also have dipyridamole and cilostazole. These are the phosphodiesterase inhibitors. Okay, these are the phosphodiesterase inhibitors, and also they are adenosine. Okay, these are adenosine reuptake. Okay, these are adenosine reuptake inhibitors. Again, we have phosphodiesterase inhibitors, dipyridamole, sorry, and also cilostazole. Now, ang question here is, bakit sila nagkakos ng bleeding? Upang maintindihan yon, let us have first the enzyme phosphodiesterase. Sulat natin na phosphodiesterase. Before we discuss the actual MOA of the drugs, let us tackle first the enzyme being blocked by the agents. Ang phosphodiesterase is the one that metabolizes or that breaks phosphodiester bonds present in CAMP. Okay? Again, ang phosphodiesterase is an enzyme that metabolizes or degrades CAMP, forming inactive AMP. Again, phosphodiesterase is the one that metabolizes CAMP, forming inactive AMP. Remember, ang CAMP ay important as we discussed previously. Okay? Important ang CAMP in causing bleeding, di ba? So, use of dipyridamole and cilostazole by blocking phosphodiesterase would mean increase in CAMP levels. Okay? Would mean increase in CAMP levels. What can CAMP do? Remember, kapag mataas ang CAMP levels, ang ultimate effect niyan is less glycoprotein 2B3A activation. Okay, that causes less glycoprotein 2B3A activation in the platelets, thus inhibiting interplatelet binding. So pag na-inhibit natin ang interplatelet binding, there is inhibition of platelet aggregation causing bleeding. Okay, causing bleeding. Okay, kaya nagpapableed ang dipyridamole and cilostazole. Okay, what else? Aside from increasing CAMP levels, or aside from lowering GP2B3A activation, what else? Bukod dito, ang dipyridamole and cilostazole can also enhance prostacyclin. Okay? It can also enhance prostacyclin levels. And remember, ang prostacyclin is also important anti-aggregant that is promoter of bleeding. Kaya pampadugo ang dipyridamole and cilostazole. Okay? So yun yung action na may kinalaman sa phosphodiesterase inhibition. Next, paano naman yung adenosine reuptake inhibition or adenosine uptake inhibition? So yung adenosine uptake, o para malinaw, burin natin yung REA, okay, adenosine uptake inhibition, ano yung effect ng adenosine uptake inhibition? Tandaan, pag may adenosine uptake inhibition, ibig sabihin yan, pine-prevent ng dipyridamole and cilostazole ang pagbalik ng adenosine sa kanyang storage site. That's why greater adenosine would be available for action. Yeah, greater adenosine would be available for action or binding to the receptor. At isang pinupuntahan niya ay ang adenosine 2 receptor. Kaya ang effect, by enhancing adenosine levels, there is adenosine 2 receptor activation. We discussed this in arrhythmia, I guess, in arrhythmia, that activation of adenosine 2 can cause vasodilation. Okay? It can cause vasodilation. So therefore, ang dipyridamole and silostazole ay mga vasodilators as well. Okay? So they are vasodilators. However, so yan yung actions ng dipyridamole and silostazole. However, please note, please note that dipyridamole and silostazole, they are not effective as monotherapy. Ibig sabihin, hindi sila magaling na pampadugo pag binigay mo ng solo o mag-isa. Okay? So usually, as an antiplatelet, they are being combined with other antiplatelet agents like aspirin. So combining these agents with aspirin would mean greater effect. Pero pag solo mong binigay, hindi ganun ka-effective. Okay? For dipyridamole, ang use ng dipyridamole, ginagamit siya in the conduct of pharmacologic stress test, kagaya ni dobutamine, nung diniscuss natin sa autonomics, ay parang kay dobutamine, pharmacologic stress test, because of coronary steal phenomenon. And for silostazole naman, ginagamit siya in the management of intermittent claudication. So ginagamit siya in the management of intermittent claudication. So that is for phosphodiesterase inhibitors. Now, for glycoprotein 2B3A inhibitors, we have the examples when you check your reference, eptifibatide, abciximab, and also tirofiban. Okay, so we have eptifibatide, abciximab, and tirofiban. Basically, they block glycoprotein 2B3A. Recall na ang 2B3A, these are the membrane receptors expressed by the platelets responsible for interplatelet binding. Interplatelet because this is the part na kung saan magbabind supposedly ang fibrinogen, causing aggregation, So therefore, pag binlock ng GP2B3A like eptifibatide, abciximab, and tirofiban, we tend to inhibit interplatelet binding, hence no aggregation. Kaya ultimately, ang effect ng 2B3A inhibitors ay bleeding. Usually ginagamit sila in the prevention or treatment, they are being used in the prevention or treatment of acute thrombosis, post-angioplasty, So they are being used in the prevention or treatment of acute thrombosis post-angioplasty. Okay? So natapos natin overall ang mga mechanisms of action ng mga antiplatelet agents. Going back, you can see that for aspirin, na-discuss natin na it blocks synthesis of thromboxane A2 by blocking COX directly. Meron din tayong ADP receptor antagonist. Meron ding phosphodiesterase or adenosine uptake inhibitors and glycoprotein 2B3A inhibitors. You can observe that these clotting factors do not target any, these agents rather, take to tayo. You can notice that these agents do not alter clotting factors. Hindi nila tinatarget ang clotting factors. Instead, these agents target the ones that act during the first event of hemostasis. Okay? During the first event of hemostasis. Kaya ang tawag sa kanila, anti-platelets. Okay? Anti-platelets. So just to reinforce what I discussed, these are the uses and undesirable effects of anti-platelet agents. Examples for aspirin, we have aspirin, then clopidogrel, ticlopidine, dipyridamole, abciximab, eftilfibatide, and tirofiban. You can double check the indication and also the undesirable effects. Okay? Overall, that is the end of antiplatelet agents. So regarding antiplatelets, we discussed the 4 groups. And that marks the end as well of antithrombotics. Na-discuss natin ang blockers or targeters ng mga events ng clot formation. So those are anticoagulants and antiplatelets. So okay na tayo. Next are the thrombolytic agents. Thrombolytic agents are the ones that can lyse the thrombus that has been formed. Basically, ang mechanism of action nila ay may kinalaman sa plasmin, kung paano ba nagagawa ang plasmin. We discussed that last meeting. Examples are streptokinase, urokinase, anistriptase, tissue plasminogen activator, alteplase, and reteplase. So some important or some distinct information about this. Number 1 for streptokinase. Ang streptokinase ay galing sa beta hemolytic streptococcus. Okay, so this was isolated from beta hemolytic streptococci or streptococcus. Since streptokinase was isolated from a natural source, mataas ang risk ng hypersensitivity reaction. Okay, mataas ang risk ng hypersensitivity reaction. Kaya usually, nagbibigay ng antihistamine like diphenhydramine to prevent this effect caused by streptokinase. Next, urokinase naman, this was isolated from mammalian kidneys. Okay, so this was isolated from mammalian kidneys. Anistriptase is an example of an APSAC. Okay, this is an example of an APSAC. APSAC stands for anisoylated. Okay, this means anisoylated plasminogen streptokinase activator complex. So this means anisoylated plasminogen streptokinase activator complex. And then finally, for alteplase and reteplase, these are recombinant. Okay, these are recombinant TPAs, in which these agents are not associated to hypersensitivity effects compared to streptokinase. This figure explains the mechanism of action of the thrombolytics or fibrinolytic agents. As you can see, they are directed in the plasmin pathway. Remember, last meeting, plasminogen is being activated by the enzyme tissue plasminogen activator, forming plasmin. Formation of plasmin would facilitate degradation of both fibrinogen and fibrin. Once these were broken, pag nasira na sila ni plasmin, that can cause bleeding already. Okay? That can cause bleeding already. So pag nagkaroon ng bleeding, ibig sabihin, pwede ma-counteract ang mga thrombotic events. That's why ang MOA ng mga agents na to is that they accelerate plasminogen activation. So pag sinabi nating accelerate, may positive sign. May positive sign tayo makikita kasi pinabibilis nga nila ang formation ng plasmin. What would you conclude pag enhance ang activation into plasmin? Meaning faster bleeding effect. Kaya nga pampasira sila ng thrombus formation. The following are the clinical uses of fibrinolytics. So they can be used in the management of acute myocardial infarction, for pulmonary embolism, central deep vein thrombosis. Also, we have thrombophlebitis. Okay? So yan yung mga clinical uses. Although not indicated here, meron tayong adverse effect niya. Siyempre, it's bleeding. Okay? So again, ang adverse effect ng fibrinolytics is bleeding. And the treatment here, or the antidote, is by using tranexamic acid. Okay, so that is by using tranexamic acid. Later, i-discuss natin kung bakit ang tranexamic acid ang antidote during fibrinolytic poisoning. Okay, fibrinolytic poisoning. So overall, those are the fibrinolytics. For the last part, we have the prothrombotic agents. Again, for the last part, we have the prothrombotic agents. When we talk of prothrombotics, these are the ones that are used for bleeding disorders. So ang goal naman ng mga prothrombotics, magka-clot, okay? Magkaroon ng clot formation para mapigilan ang excessive blood loss. Number one, we have vitamin K. We also have plasma fractions, desmopressin acetate. Also, we have aminocaproic acid and its related analog, which is tranexamic acid. Okay, analog, which is tranex or tranexamic acid. And finally, aprotinin. Aprotinin was already withdrawn from the market. For vitamin K, remember, is related to warfarin, right? But dito, para mas maintindihan natin, i-discuss natin siya, vitamin K exists in several forms. We have K1, 2, and 3. Vitamin K1 is phytonadione. This is also known as phylloquinone. Okay, this is phylloquinone. And ang vitamin K ay makikita sa mga pagkain, lalo na yung mga green leafy vegetables. Ano ba yung mga green leafy vegetables? Pechay, kangkong, mustasa, yun yung mga green leafy vegetables. They are actually rich in vitamin K. Green leafy vegetables. They are actually rich in vitamin K, K1 lalo na. So, ito yung form ng vitamin K na ginagamit during warfarin poisoning. Okay? Siya yung mismong antidote. Na-discuss ko earlier ang reason ng antagonism between warfarin and vitamin K. So, therefore, may connect natin siya sa isa pang drug interaction na kapag umiinom ka ng warfarin at mahilig ka sa mga pagkain ito, that could lessen warfarin's effects. Okay? Next, vitamin K2 is found in intestinal flora. So that is menaquinone. And vitamin K3 is the exception. Why? Diba, as we know, generally vitamin K is a fat-soluble vitamin. But there is a specific form of vitamin K na water-soluble. It's menadione. And this is the form that is ineffective during warfarin poisoning. Okay? So dalawa ang clinical uses ng vitamin K. Una, for prevention. Second is for the treatment. For the prevention, that is to prevent hemorrhagic disorder of newborns. Okay? That is to prevent hemorrhagic disorder of newborns. And also for treatment, ginagamit nga siya during warfarin toxicity. So treatment of warfarin, warfarin toxicity. What form of vitamin K again? It's K1. Okay, it's K1. Next, plasma fractions. Usually, plasma fractions are being used for certain genetic disorders, lalo na for those patients which have or who have deficiency in certain clotting factors. For instance, for patients with hemophilia A that lack factor A, and hemophilia B, those patients that lack naman factor 9. So classic hemophilia is factor 8 deficiency, while Christmas disease is factor 9 deficiency. So ang example niyan is Umate, that is the brand. This is actually a factor 8 concentrate. So somehow, nagsasupplement tayo ng lacking na factor, and that is factor 8. Used for particularly factor 8 deficit patients, and also those patients with von Willebrand disease. Yung patients naman na may von Willebrand disease, mababa ang von Willebrand factor nila, ay von Willebrand factor. And we discussed na ang von Willebrand factor is important for platelet adhesion, right? Ang isa pang distinct kay Umate P, meron siyang increased amount of von Willebrand factor. So nasa supplement ka. Next, we have desmopressin acetate. Desmopressin acetate can enhance also factor 8 activity. That's why they are effective in patients with hemophilia A. Kasi ang hemophilia A ay kulang ka ng factor 8. It's not effective in Christmas disease. And then von Willebrand pwede rin gamitin kasi it can enhance von Willebrand factor in patients with von Willebrand disease. Okay? Next, cryoprecipitate. Okay, next we have cryoprecipitate. Cryoprecipitate contains protein fraction obtained from the whole blood. Okay, obtained from the whole blood. Ang makikita naman natin dito ay fibrinogen. Okay, so ang makikita naman natin dito ay fibrinogen, which is an important substance para ma-induce ang platelet aggregation. Di ba siya yung bridge? So important siya in patients with abnormality in fibrinogen level. And it can also be used in patients with factor VIII deficiency and von Willebrand disease. Next is aminocaproic acid. Aminocaproic acid is a compound that came from the amino acid lysine. Kaya galing siya sa lysine. And ang action ng aminocaproic acid is in the ang action niya or ang MOA niya is that it inhibits plasminogen activation. Okay, it inhibits plasminogen activation. So when you check the action of aminocaproic acid, somehow it is related siya sa pinakita kong figure kanina. Kung ang fibrinolytics, they can accelerate, kung babalikan nyo, they can accelerate plasmin formation. Ang aminocaproic acid naman, naka-negative symbol siya kasi ang aminocaproic acid ay taga-inhibit ng activation. So, pag taga-inhibit ng activation, walang plasmin, right? Walang plasmin. Therefore, walang pagbibleed. Kaya ang effect ng aminocaproic acid ay clotting. Kaya nga ginagamit siya for bleeding disorder. That's why aminocaproic acid is being used for bleeding disorder. Also, meron tayong analog related to aminocaproic acid. It's Tranex. Di ba nasabi natin siya kanina? So ang tranexamic acid, it also inhibits plasminogen activation. Kaya antidote siya ng fibrinolytic poisoning as we introduced a while ago. Negative symbol kasi siya. Going back to aminocaproic acid, this is being used as an adjunctive therapy in hemophilia to prevent further bleeding. And then, prophylaxis for rebleeding has been used in patients with post-surgical GI bleeding and post-prostatectomy bleeding. Lahat na may kinalaman sa bleeding, usually, ginagamit ang aminocaproic acid. Adverse effects are as follows. You can check them out. And then, as we said, meron tayong analog that is Tranex, o na-discuss ko na siya. And tranexamic acid, just like aminocaproic, is being used in the prevention and treatment of post-surgical bleeding. Okay? So, yan ang tranexamic acid. Going back with the lecture, we discussed the agents that can be used for bleeding disorders like vitamin K, plasma fractions, desmopressin, aminocaproic, and Tranex, and then yung withdrawn na aprotinine. So from the beginning of drugs for coagulation until now, that's the end of our lecture. So let's just double check if really tapos na tayo. Number one, diniscuss natin live yung hemostasis. Okay, second, diniscuss din natin ang antithrombotics. Ito yung mga anti-coagulants at antiplatelets. Tapos na tayo dyan. Thrombolytics or fibrinolytics, tapos na rin, and prothrombotics. So that's the end of my lecture. Okay? So that's it.